Hi everyone, I'm Isabel Kai with the New England MHTTC. I'm just gonna go over some housekeeping items. If you can advance the slide, Daisy. Thank you. So participant microphones will be muted at entry. You will be able to unmute your microphone at designated times during our event. We offer closed captioning. You can click on the closed captioning CC icon at the bottom of your Zoom screen to select a transcription option. This session is being recorded and will be available on the MHTTC website within 48 hours. If you have any questions during the event, you can always raise your hand, use the chat box. If you have a tech or logistics question, you can message me privately. I'll be here. And if you have questions after this session, please email newengland@mhttcnetwork.org. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, and person-first and free of labels. I'm going to turn it over to our wonderful presenters, Daisy and Stephen.
So welcome all, and thank you for taking the time out of your day to sit for this presentation and most importantly, investing in knowledge increase and knowledge sharing. My name is Daisy Hernandez. I identify with the she group of pronouns, and as a woman in sustained recovery, as well as a woman who has successfully reintegrated her family and community from commitments to the DLC. I'm checking in from Western Mass. Shouts out to anyone in Massachusetts and everyone else, where I'm licensed as a licensed certified social worker in the state of Massachusetts. My current role is as a director of peer recovery TA for the Massachusetts Recovery Education Collaborative, which will launch in January. I want to invite Stephen to share an intro if he'd like.
Absolutely, Daisy. Thank you. And it's really great to be here with you and with everybody else. Some of you may just remember I'm Stephen Samra. I'm a person in long-term recovery from what I call the big five of behavioral health challenges. And I am coming out of Nashville today and have been this series has been really powerful in the sense that it reminds me of the amount and the challenge of the work that we do. So that everybody's here. I see folks from all over the country. I see folks from public health, from corrections, from peer organizations. It's fantastic because we desperately need a national movement around recovery and particularly around criminal justice challenges. So with that, I'm giving this back to Daisy. Daisy's going to lead us through today. I'll chime in a little bit. I'll probably be working in the chat and looking forward to finishing up this session, these sessions with all of you. Thanks, Daisy.
You're welcome. I'm big on the engagement of pulling in your knowledge and experience. It helps your peers grow. It helps us facilitators grow. But before we get into the meat and potatoes here of this presentation, being that it's Friday, if you're like me and running on fumes, I would like to act as a meteorologist of feelings and emotions, right? And I don't want to get all touchy-feeling like a therapist, but follow me, right? The work that we do is from the heart. It is valuable to check in with ourselves and kind of gauge our temperature. And so I want to invite you all to take a moment to scan your thoughts, your body sensations and emotions. And on chat, share one feeling word of how you're feeling right now. Just one feeling word. And go ahead and let it drop like waterfall and share kind of like your own temperature report. Karen, make sure you take some deep breaths behind the scene. Stretch, hydrate. I'm sorry you feel worried, Jen. I hope that you can find some peace. Oh, I hope things turn for you, Ali. Calm, happy, hopeful, tired, overwhelmed. Thank God it's Friday, right? Friday. Awesome. Hopefully, this serves not just as a training opportunity, but an opportunity to just be present and in the moment. And with that said, thank you all for, participating in that. It's probably off kilter, right? Something you're not used to, but it's important to check in with ourselves, especially doing the work that we do. But again, hope your weekends are filled with rest and recharge. I'm with you, Maria, TGIF. So what we hope you can walk away with at the end of this presentation is having a better understanding of the impact and landscape, what the numbers say. Increase your knowledge of the challenges and barriers to reentry. Discuss some strategies for improving success to reentry. Increase an understanding of trauma-informed care through a review that we'll have, and have a better understanding of recovery-oriented systems of care and how wellness fits into it, and increase awareness of the power of peer support services. Now, the incarceration of women and girls has grown at twice the pace of men's incarceration in recent decades, and has disproportionately it's disproportionately happening in most and mostly in local levels like jails, right? A staggering number of women who have incarcerated who are incarcerated are not even convicted. Most of them, 60% of women are in jails under local control, have not even been convicted of a crime and or are awaiting trial. Aside from the women under local authority or jurisdiction, state and federal agencies also pay local jails to house some individuals. For example, ICE in the U.S. Marshal Services have fewer dedicated facilities, and so they, utilize local jails to house roughly around 3,200 women. So join me and let's take a look at some of these numbers. Avoiding pretrial detention is particularly challenging for women. The number of non-convicted women are stuck in jails, and surely not because courts are considering women to be a flight risk, particularly when they are generally the primary caregivers of children. The far more likely answer is incarcerated women who have lower income than incarcerated men have an even harder time offering up or having access to bail, money for bail. When the typical bail amounts to a full year's income of the woman. If you notice here, in this pie offered in an article from Prison Policy back in March of this year, majority of women are held for poverty crimes, drug charges, and public order, which also tells us they don't have the money to pay for some of these bails, right? It also highlights that violent acts has the least amount of women who have that as an offense. Also, the representation of these charges is also represented in the state prison. So for the same, charges in that same order, which is, poverty crimes, drug charges, and public order, as well as of violent offenses, and they align for those women that are in the state level of, I call it care because I feel like corrections has a responsibility to provide a certain level of care services versus correction services. But that's my own daisyism, and I'll jump off my soapdish. It's too early on the presentation for me to do that. But women in state prison are more likely than men to be incarcerated for a drug or a poverty offense. 25% of women in prison have been convicted of a drug offense, compared to 12% of men in prison. 19% of incarcerated women have been convicted of poverty crime, compared to 13% among incarcerated men. So I would like to invite you on chat to share something that resonates with you from this chat, from this chart. The picture is blurry. Oh no, you know what I could do? I could put the link on chat so you can get, just as a resource. I don't know, maybe when we start, in my screen it doesn't look blurry. Maybe because I don't have my glasses on, but
Daisy, when I expand it, I mean, if it, when I enlarge it a little bit to read it, yeah, it does get kind of blurry. I'm not sure why, but
Oh, when
it
it's
does.
enlarged, probably.
Yeah,
I
and
did. I sent the link though, so you can have a clearer access to the full report or the article from the prison policy. How's this one look? Much better. Awesome, awesome. So, women's incarceration rates have grown dramatically since the 1980s. But in contrast to the total incarceration population, which is overwhelmingly male, women's jail rates have grown about equally to their state prison rates, right? And this is jail equally to the state prison level. The proportion of imprisoned women convicted of a drug offense has increased from 12% in 1986 to 25% in 2020. Any reactions or thoughts on why? And you can jump on chat and share. That one is easier to see. Okay, I see Ellie. Any reactions from that data that increased from 12% to 25%?
Elizabeth is asking, Daisy, is there an increase in women's drug use?
And that is the biggest factor, right? Of women act or need for support around drug use. And in some ways, incarceral settings have become right, at least in Western Mass, our county jail is also now our Section 35 as well. And they're counted as a prison count, not as a mental health count or a treatment count. And there's entities fighting against that, but just a knowledge, yes, it's because of the women's increased use, right? And in certain situations, sometimes it's just drug possession, right? And again, it speaks to our history of criminalizing drug use and mental health, right? As you've seen in the previous numbers, the women are being incarcerated for property crimes, drug crimes, and orderly, right? Or civil behavior stuff. And so oftentimes there are women that are with a mental health disorder and or a substance use disorder, which impacts those numbers even more. But are they also offering treatment, support, and services while they're incarcerated before their reentry, or are they just waiting to tag in community services to support those needs? Absolutely, Jennifer. Thanks for highlighting that. COVID caused the dip, but the sharp increase in 2021 indicate the continued increase of women incarcerated trend. I appreciate you for highlighting that because COVID did cause a dip, but it also showed that there's a possibility for alternative sentencing, right? So now that COVID is not over, why we can't still access some of those strategies of alternative sentencing, and we're just ripping women away from not just their communities, but their families, their children's, right? Probably due to a lack of resources for women. Darlene, see, y'all gonna keep pushing me on my soap dish. We're in like slide 6 or something, because it's so true, right? Yes, men are higher population, but men have more support services. And Stephen, I say this all the time, and there's a Daisyism. You go to a jail and visit a man, and the visiting room is filled a couple times a week. You could go there every day of the week and you'll find the same man visiting with the grandma, the aunt, the mom, the next day with the baby mama, the next day with a side girl, the next day with an ex-girlfriend. When you go to a visiting center for women, those rooms are not filled. And when you look at community services, right, around mental health, they would have 15, and this is an ick of mine as well. They'll have 15 residential treatment service for men. They'll have 1 residential treatment service for children, moms and their children, and they'll have maybe 3 for women, right? And there is a disparity, despite numbers telling us, and we'll get into that women most of the time, up to 80% of the time, report being primary caretakers of their children. And so disparities, excuse my language, for damn sure, right? Gender disparities in this case. And that's not even tapping into the racial and economic disparities where policies and insurance are really dictating where people get to get treatment, or where they're supposed to access treatment, right? Because insurance runs the world. And if you're in public insurance, now with these umbrella partnerships they have, you're restricted to be in a certain area or go to certain treatment facilities. Not everybody takes the insurance. It's a hot mess out there. It creates additional barriers for women. You know, Ali, thanks for sharing that, because prior to the session, we were talking amongst ourselves as facilitators about trauma and how women, it's easier for women to report experiences of trauma or to identify experiences of trauma, where it's not for men. Yet we create these society creates these labels and groups us by gender on what we're supposed to share and not supposed to share, what to be vulnerable of and what not to be vulnerable of. But I don't want to digress. The rate at which women are incarcerated varies greatly from state to state. At the national level, including both state and federal imprisonment, 47 out of every 100,000 women were in prison in 2021. The states with the state with the highest rate of female imprisonment is Idaho with 127 out of every 100,000. And the state with the lowest incarceration rate of women, shouts out to Massachusetts, is 6. Great work. Shouts out to Mass for doing the work, right? I know there's a conference coming up on racial segregation still in this time out of I believe is Springfield College is coming out in March, where the researcher has identified Springfield as a highly segregated town in Massachusetts, and where, you know, despite us having the 6% or 6 out of 100,000 women, the women in there are women of color and women for, again, poverty crimes, and drug-related offenses, and civil disturbance. So that 6% could potentially be less, especially for women of color, if we really were intentional about leading with equity and equality when looking at policies and procedures and even alternative sentencing. So I would like to invite you on chat again to share any reactions to this chart on the different years from 1980 to 2021. And I did have someone share COVID. Let me go through the chat here. Lack of resources for women. Yeah, we kind of tapped into that. Thanks, Stephen, for caring for our chat. Appreciate your support. Now, since we're on the topic of racial disparities, anyone who lives in or works within heavily police, right, and carceral, and not incarceral, what's it called? Incarceral state, but high policed state. Intuitively, we know that certain neighborhoods disproportionately experience incarceration. Now, a term that I would love to introduce to you all is prison gerrymandering, right? The practice of counting individuals where they are incarcerated versus counting them where they last called home. Even if an individual was homeless at incarceration, their last known address should be identified as their address, but it wasn't actively, because gerrymandering actively works against the notion of equal representation, and that is foundational to our democracy, right? And how we can have individuals represent us in some of these policy advocacy and that kind of stuff. But California, Colorado, Connecticut, Delaware, Maryland, Montana, Nevada, New Jersey, and New York, as well as places like Pennsylvania, Virginia, and Washington, are among the 12 states right now that are have ended prison gerrymandering. And the need for this reform is crucial for ending the political power siphoning of disproportionately Black and Latino communities to pad out the mostly rural, predominantly white regions where prisons are located. Any thoughts? Chat. Oh wait, let me jump on chat. I know Stephen got it, but Stigma and bias create the public stigma and internal. Even amongst those that represent us to make changes, right? And that is what fuels some of this disproportionate access to and or dismantling some of the lack of equity in which services funding are also allocated. Jess, I'm not sure, but I would say I got the article from the Sentencing Project. And it was a full article on gerrymandering, but if you Google it, Google University, right? I'm sure that it'll help identify, which additional states are either working on some policies, more maybe policy-driven stuff. All right, so now with recidivism rates, I hope that was helpful. Never realized this carceral gerrymander is going on, especially disturbing since so many adults in custody are this as well, right? And how we allocate those funds too, if a population who already has enough funds, and now we're counting individuals and who are incarcerated as part of that space or community or environment, and there will, because there's more people, the allocation of funds will be higher in that area already. And in addition to, but recidivism rates in the US are some of the highest in the world, with almost 44% of individuals released returning to prison within their first year out. The median number of prior arrests among females was 7 compared to 8 among males. Females were less likely than males to be arrested, convicted, and returned to prison within 5 years of this study. Now, or their release. The percentage of females who returned to prison within 5 years was higher among those serving time for a property offense than a violent offense. Right, and that speaks again about my ism. If women are being incarcerated for poverty crimes, how are we supporting their financial independence? Poverty crimes. How are we supporting their financial independence upon their release? Now, where are we jumping in? Oh, why my slides stuck? There we go. There are clear correlations between challenges and barriers to successful reentry. So let's just tap into our next couple of slides for a quick review of what those are. Okay, so women are more likely to be parents of minor children, more likely to be single parents, and more likely to have been living in with their children and being head of household prior to their imprisonment, making it more likely that incarceration would uproot their children and lead to termination of parent rights, worst case scenario, and permanently breaking up their families. Not to mention, right, I always say that the children are like silent victims of mass incarceration because, we have data to tell us this is why women are being incarcerated. This is who they are prior to incarceration. And then we separate them and uproot them from all they already have established, independent whether it is theirs or they're sharing it with somebody else. But then we send them back to the community with the same kind of challenges and barriers they had upon entering the incarceration. I would like to know about overdose rates also for Black and brown folks compared to white males. And that's not a slide. I will mention it as an overall topic, right? But I don't have exact rates. At least I know that in Massachusetts and possibly across the nation, although, and I can only speak for data in Mass right now, that although our overdose rates are decreasing, they're still increasing for general population. They're still increasing for members of the communities of color. Most definitely email, thank you. Different here in the male prison where women want to marry these guys while they're in here. These incarcerated women have no visits. I just tapped into it prior to your or maybe you missed it. Here in Alaska, we have one of the highest recidivism rates over 60%, and maybe more technical violations. Oftentimes, right? And if they don't have the support necessary, how will they sustain or successfully reenter their families and community? But while stays in jails are generally shorter than in stays in prison, jails can be specifically deadly for women. Women have a higher mortality rate than men in jail, dying of drug and alcohol intoxication of twice the rate of males. And the number of deaths by suicide among women in jails increased by almost 65% between the periods of 2000 and 2004. And then there was an also increase in 2015 to 2019. Over a quarter of women, about 26%, experienced homelessness in the year before the arrest that led to their incarceration. And there's also a higher rate than among, that's also a higher rate than among men, with men is like about 16%. Women are more likely to be jobless, which hence speaks to, poverty crimes. And that represents 50% of women who report being jobless than to be employed in the months before their arrest. And this is the timeline before their arrest. Women are more likely than men to enter jail with a medical problem or a serious mental illness. And while incarcerated, women are more likely to suffer from mental health problems and experience serious psychological distress. Women report disabilities 50% of the time and physical and mental health problems at a higher rate than men. Overall, 58% of women meet the criteria for a substance use disorder the year before they were incarcerated, and over 3/4 of, or 76%, has some indication of a past or current mental health problem, both significantly higher rates than among men. Yet 47% had received treatment for substance use disorder, and just 43% had received professional mental health care since they were incarcerated. And while incarcerated, women are 3 times as likely as men to be sexually victimized by prison or jail staff. 3 times. Those are the women who have reported, right? You can just imagine the women that have not reported, not knowing their rights, being scared of or intimidated, whatever those barriers or challenges are to reporting. And I appreciate you all for tapping on chat and keeping Stephen busy here. I appreciate Stephen for his support on the chat. I hope I'm able to, at least touch into some of those as we go along. And I don't know why my slide gets stuck. Okay, there we go. Now, intersectional stigma is the convergence of multiple stigmatized identities and can also impact behaviors, mental health, and physical health. We already know, right, that mental health and substance use disorder is a highly stigmatized need in some of the women. When we think about women, right, they're not supposed to be in jail, says, I don't know who, not us, people that live in like Mars or something. But that's a stigma. And then when conditions like, poverty, factors of poverty, homelessness, joblessness, it creates these intersections for women to the impact of women's confidence and even, their self-esteem on their ability to return to the community and, do what they have to do to, live a life of wellness and stability. Now, the invite here with these barriers, any barriers that I have not captured here that in your work experience or even personal experience you think should be here? Education, Tamika shared education. Those were and I had them asterisk. I didn't put them not on purpose, but just to have a conversation with y'all because I like that interaction. Those were the top 2 I was looking for: education and transportation, as well as peer support. And I did tap into that earlier, just that 80% of women in prison do report being primary caretakers of their children upon intake at a prison setting. Trauma. And we'll get into a little bit of that. And I got some slides coming up further on post-traumatic growth, because majority of women do experience trauma. And when we think of, here I go with a Daisism, right? Data says, it's really interesting, right? Because I'm big on data. Medical data leans towards genes, right? And the development of a substance use disorder or mental health. Behavioral health and mental health data leans towards marijuana as a gateway drug. Daisy's data, based on her peer coaching and supervision experience and her clinical experience and her professional experience and everything I learned from my peers and people that are participants in training, trauma is the gateway drug for addiction. Our thank you, Jess. Absolutely, right? And this is why post-traumatic growth is so important, and I hold it at such esteem from the moment of intake. How are we influencing and encouraging post-traumatic growth? And not just women, but also in men, even though Steve and I were talking about earlier how much harder it is for men to identify and verbalize the need for support and healing from trauma. But I'll leave the man on standby. I'll leave him in the parking lot right now, right? We're focusing on the women. But trauma is the gateway drug to addiction. Our fight or flight instinct is not naturally set up to be activated at all times, right? And when one experiences trauma, that fight or flight instinct becomes disordered, right? Because it's doing something that it's not supposed to do. And so we have to intentionally, as providers, organizations, and peers support individuals in identifying this trauma and making that linkage, being like we say in peer recovery support, right? Recovery coaches, be that broker, right? That resource broker to connect to the things that would encourage and empower post-traumatic growth. And because we can grow, right, around the trauma while we're working on the trauma. But I don't want to, keep rambling on. Thank you all for, again, your support on chat. And we're all on the same page and it makes me feel warm inside. What are some strategies to be aware of to increase or improve successful reentry for women? First off, right, gender responsive programming. Anyone familiar, use your reaction buttons, thumbs up, thumbs down, familiar with gender responsive programming. A little self-explanatory, but it's more to that. Everyone know how to use the reactions? Thumbs up, thumbs down. I got my screens on the other side. Nice. At least one person, two people know or are familiar or heard of gender responsive programming. Now, men and women experience different pathways to crime and addiction, as well as alternative trajectories of drug use. Women's drug use and associated criminal behavior are more likely to transpire within interpersonal relationships and are strongly associated with the behavior of romantic partners. Histories of childhood maltreatment and abuse, somebody mentioned ACEs on chat, co-occurring psychiatric disorders, family dysfunction, and negative self-concept are also more common around or among criminal involved females compared to their male counterparts. Women in the criminal justice system are more likely than the general population to suffer from a number of mental health disorders, including depression, anxiety, borderline personality disorder. And these are things like post-traumatic stress and other mood disorders like, it just flew my mind. Bipolar disorders, schizoaffective disorders, and those types. Similarly, females who commit crimes are more likely than males to report both substance use prior to incarceration and a prior mental health, which, we know the data shares that majority of people, I think it's up to like 90 or 99% of individuals who identify with a substance use disorder also have a co-occurring disorder, which leaves only about 1% that only have a substance use disorder. So co-occurring disorders are a prevalent conditions for women who are incarcerated. And this has a significant implications for reentry, as both conditions are predictive of higher recidivism and as well as of relapse rates. Given the documented gender differences in cause of disease or disease progression, motivation for treatment, and self-efficacy, right? On how we have that autonomy to move forward with our life goals towards, whole wellness. Now, practitioners and researchers have called the gender responsive programming in prisons and reentry spaces and rehabilitation a necessary part of programming. And gender responsive programming is underpinned by 4 theoretical perspectives. So let's tap into, what those 4 theoretical perspectives are. The 4 perspectives here suggest that women's path to incarceration are often triggered by gendered experiences of abuse and socioeconomic disadvantage rather than criminogenic behavior. Now, relational theory is the second one here, but with pathways, right, that suggest that the path of women is different. Anyone have any reactions to that? I think we've kind of shared some of the evidence prior to this deck or this slide, but I'm open to any other additional thoughts. Just because I like the interaction. So the pathway theory is the first one, right? How they get there and what those differences, disadvantages are. The other theory is, ooh, nice, Stephen. You know what I would love to see if I was queen of ACE assessments happening, or a new version of ACE to be developed, where it's peers who develop it and are part of, doing the research on the community. You want to add anything to that, Stephen? I see you.
Thank you. And I do, because, the adverse childhood experience, quiz or questions and how that, those were developed. There was a heavy white influence. And there was a lot of stuff that just did not cross into Black and brown, perspectives. And there is an effort underway right now to add racism as one of the ACE scores. And I believe that they're trying to come at this exactly as you just described. It needs to be diverse. There needs to be broad perspectives. And we need to talk with folks about what was adverse in their childhood outside of sort of the, kind of the white mindset. And this is not bashing, white folk. It is just saying that the lens for ACEs was originally done, as part of white privilege, honestly. Mm-hmm. And they are working to reform that, because it's been folks like us who have said, we think you might have a problem here. And this doesn't apply to everybody. So, you get an ACE score as a Black or brown person, and it's got some value, but it's missing some of the critical areas that should be addressed, outside of white privilege. So all that to say, I think it's underway, but I really think that peer voice desperately needs to be in that. So thank you.
I totally agree. I think cultural representation, right, too, and identifying what communities people come from, because we know that historically data has showed us of that impact of racism, and just shared on the programming not being trauma informed. And let's start with the guards, staff members in some of these settings, right? With this tactical and clinical training they're limited to, I think there needs to be a better, professional development for that setting of trauma, responses, right? We have the tacticals like an inmate that's in the middle of the unit acting up. It's a restraint and shackled, and that inmate could very well have come from a space of rape, abuse, and that kind of stuff. What's that doing? What's that tactic doing for the individual? If the individual is not coming at a guard with a knife or a weapon, why we got to restrain them in that way? But that's again some of my own Daisyisms. But I mean, I voiced that even in my clinical setting because I still am working towards my LI, and I've brought up PHQ-9s and the GAD-7 and how it's not gender responsive because society, right? And historically, we know some behaviors are acceptable for males and little boys versus females and little girls, right? And that impacts how we receive those PHQ-9 responses or how they respond to those questions in the PHQ-9 and the GAD-7. But I don't want to get all clinical. Now let's jump into the relational theory, right? And this it posts that women's experiences in the criminal legal system are more likely than men to be based on violence and exploitation, and that gender responsive practice should therefore work to build a sense of connection with others. We know upon reentry, and shout out to any reentry workers in the room, but we know that women have different needs than men, right? Upon reentry or entering the incarceration setting or reentry into their community and families. But we're not, if they're being supervised, not even at the supervision level of probation, parole, or even DCF, understand the different needs because they impose all these release conditions that sometimes work against each other and don't allow the women the space to, do their work on strengthening a recovery program or building a relationship with their family, especially their children. Now, the addiction theory understands that addictions are not inherently criminal behaviors, but rather disease that reflect complex emotional, psychological, and social cultural problems. But yet, we know this, and yet our society criminalizes people who have substance use and or mental health. Many states are moving towards mental health court or drug courts, which creates an opportunity for men and women, but we're focusing on women right now, right? To have these opportunities to not walk away from their commitments with a criminal report, right? A query or criminal charges. Now, the addiction theory also understands that gender responsive programming must target the person holistically to eliminate substance use behavior. And that holistically, right, it's important to really look at trauma because it's not just stopping the use or being in a recovery program. It's really working intentionally through a lens of wellness, right? Not just stopping the use, but wellness and quality of life. All right, here we go, party trauma. So with the trauma theory, yeah.
I was just getting before you jump in there. As we were talking about that, what we're really talking about is whole person care, right? And the scope around that. And you can treat an addiction, you can treat a mental health challenge, you can treat environmental issues, but if you don't treat them all, those drive the trauma responses, right? That's what's driving a lot of that. So, we really need to, and I think we're getting there, just kind of reframe how we're coming at people. Because if we're just treating one thing, how many of you have heard that, oh, Bob went to rehab, he's been in there 30 days, he's all better? 30 days when I was in active use, that would have just gotten me clean enough that I really wanted to party when I got out because I knew I would feel those things. What I needed was a piece of support around that. I needed a mental health eval, something I wouldn't have done at the time because of stigma. I really needed somebody to help me establish boundaries. How do you return to life? How do you do that? And without that, that village around me, it was 10 times as hard to navigate myself back into mainstream as I'm watching our brothers and sisters who have good, solid peer support are able to do. It's clear, right, that, as a peer, we get, I think, in a bigger way, that whole person health need. Not that, our providers and clinicians don't. I think everybody does, but we drive that, I think, more so than in the past. And it's because we can point to the evidence of recovery when we've come at folks whole person care or whole person approach. So I just wanted to share that because it's really an important piece for us to keep in mind now.
I feel that, and we'll jump into in the next couple of slides, right? With spanning from the trauma theory, that whole person's care or that whole person approach, it's really the wrapping that keeps all these four theories together, right? Because I think, and at least for me, I think it's more than just A, treating a substance use, B, treating a mental health, C, treating a trauma history. Because the individual is more than that, right? The individual in the community is an employee, is a mom, is a student maybe, and I always, like, even when I was working in peer support as a peer recovery coach and as a supervisor, I prioritize that whole wellness. An individual is more than just these diagnoses, right? And improvement in quality of life is more important to me than, checking off the boxes of goal attainment, if that makes sense. But the trauma theory argues that because incarcerated women are more likely than incarcerated men to have experience with physical and sexual trauma in adolescence, adulthood, programs must take the trauma into account and understand the impact of trauma in the women's thoughts, feelings, and behaviors. Programs should therefore strive to be trauma-informed, trauma-responsive, and trauma-specific, right? Somebody mentioned it in chat earlier, right? You treat the trauma, you treat the addiction, and that is so on par with all of that, right? And gender-specific, and what we're about to get into here with trauma-informed care. So trauma, in its essence, is the exposure to an extraordinary experience that presents a physical or psychological threat to one's self or others, and it generates a section or reaction, of helplessness and fear. And this is per the American Psychiatric Association. There's a great significance in the understanding of trauma-informed care when working with incarcerated women and its impact on recidivism rates. There's strong evidence associated with low recidivism rates for those who participate in trauma-informed care and trauma programs that for those who that don't participate in trauma-informed care than those who do participate. For many decades since the first ACE study was completed back in 1998, trauma or evidence has continued to grow, this demonstrating this fact that trauma impacts a person's life span, not just certain periods of their life. Cycles of abuse, neglect, and dysfunction continue and can often be predicted. Stigma, lack of empathy, and fear further perpetuate these tragedies. Trauma-informed care, it seeks to support the recognition of adverse childhood events as well as those experienced as adults, because the culture of active use does also expose us to many potential trauma situations. Now, feel free to add on chat your reactions to, and this is my Daisyism, another one of my Daisyisms, right? That trauma is not the exception, but the expectation. Any reactions to that? Singing to the choir, right? All right, here. With trauma-informed care, there's 6 divisive features. It supports mindfulness, ownership, and forgiveness. Trauma-informed care leads those treated to the identification of impactful events, and it empowers them to reclaim control over their lives, emphasizing physical, psychological, and emotional safety. The Substance Abuse and Mental Health Services Administration identifies these 6 principles that are fundamental to a trauma-informed approach for services, systems, and stakeholder groups or individuals being served. With the first one, safety, throughout the organization, providers and the women they serve should feel physically and psychologically safe. With trustworthiness and transparency, that identifies with the trust feature, organizations and providers, their operations and their decisions are conducted with transparency, and the goal of building and maintaining trust among not just the providers or the leadership, right, but the women and the family members of those they are serving. The third one here with choices, I often, relate this one to, peer support, mutual support, but these are integral to the organization and provider services delivery approach and are understood as key vehicle for building trust, establishing safety, and empowering. We'll get into that one. Collaboration and mutuality. Under collaboration, there's a recognition that healing happens in relationships and in the meaningful sharing of power and decision making, right? Allowing the individual, the woman, to have autonomy and controlling decisions of what their recovery program looks like, be it a substance use disorder or mental health or even a trauma program of recovery. And the organization and providers recognize that everyone has a role to play in a trauma-informed approach, one that does not have to be a therapist or a doctor to have a therapeutic relationship or a trauma growth relationship with the individual. Empowerment speaks to the voice and choice of the individual, but organizations and providers should aim to strengthen the staff, women, and family members' experiences of choice and recognizes that everyone's personal experience is unique and requires an individualized approach. We learned a long time ago that the recovery from anything is not a cookie cutter format. Even if we were in a clinical space and let's say Stephen and I were going in for, I don't know, treatment of diabetes, our treatments are going to look different, right? Whatever it is they give us is going to look different because we're 2 different individuals. And so, empowerment of voice and choice should be founded in the fact that we are all unique. And when we think about it culturally, right, we see addiction and mental health different, right? Which means that our recovery to it is also different. And speaking about a little bit of everything, right? Our cultural, historical, and gender issues. It's also important when it comes to trauma-informed care. And the organization and providers actively move past cultural stereotypes and biases, offer culturally responsive services. They leverage the healing value of traditional cultural connections and recognizes and addresses historical trauma. Because the trauma is more than just, the physical, emotional, psychological, and the sexual. Any thoughts so far? Questions? Jump on chat and we'll be happy to support. Now, another aspect of supporting successful reintegration. Life after traumatic experience is never easy. This is certainly the case for women, right? Having higher rates of trauma as part of their trajectory. For many women incarcerated, committing a crime might be a traumatic experience in itself and may confront them even more with the consequences of, an incarceration. Post-traumatic Growth should be considered not as an alternative, but as a parallel process with respect to negative psychological consequences. Post-traumatic growth may feature positive change in self-perception, interpersonal relationships, and philosophy of life, right? How we see people in the world, because that's altered after a traumatic experience. A greater appreciation for life would speak to appreciating the value of one's life or appreciating each day in a way you didn't before. Because trauma has not just that self-awareness change, right? But also that psychological change. And research shows that your brain does change after an experience of trauma. And with new possibilities, such as developing new interests, a new life path, or willingness to change things that one has that gains that self-awareness of needing to change. Personal strength, the knowledge that you can handle difficult things, that you're stronger than you thought, or an increased sense of self-reliance. When I talk about post-traumatic growth with the people that I work with, I always bring them back to the intake. And I have very small percent of people at intake who, when I ask them the question, oh, can you tell me some of your strengths? Most people are like, what's that? I don't know. Right. And I have to pull it out of them and asking these good open-ended questions of things that they told me they've been through, and then they still, or they're doing, and they're, resilient with it. Because a lot of people don't see those strengths. Now, with spiritual change, a deeper understanding of spirituality or strong faith than before. Sometimes people come, in their worst state and broken, and they don't believe in a higher power. And I think that some part of our responsibility is also to teach that difference between spirituality and religion, so that people have some hope even when they're not connected or don't believe, if that makes sense. But the initial shock of incarceration challenged female prisoners' assumptions to the world, but they managed to overcome the crisis by finding meaning in the prison experience and sometimes using it as an opportunity for personal development, right? You're stuck in this horrible place and you're like, all right, well, I really need to make some changes. And that's often the helps catapult, if that's the right word, to do and take action and kind of make different healthy choices. Any questions so far with post-traumatic growth? Steven, you
Daisy,
want to?
sorry,
Go ahead.
two
No,
quick
go ahead.
comments. And I don't want to cut anybody off if somebody's got their hand up or wants to speak. That trauma worldview piece is really important for us to understand, because it does shift your worldview towards one that is more fearful, more pessimistic, more untrusting. There's a number of things that happen in that worldview shift. And I usually will say to people, I make the comparison between my wife, who has a trauma event, a major, she was raped in her 20s. And it was a violent rape. And it, certainly was a trauma event that has left her traumatized. But the difference between what happened to her and my complex trauma that went through most of my childhood is that my wife still sees the world as a fairly safe place where people will be kind and they'll do the right thing if they get the opportunity. My worldview is exactly the opposite. And in some ways, my wife helps balance that out a little bit, but I can't get rid of that worldview. And the other piece of it is I have absolutely no way to get to 100% trust with anybody except my dogs. And I've been with my wife 23 years, and I trust her 97%, but I will always carry a wall, because particularly with complex PTSD, it's relationship trauma. And the people who were, charged with caring for you, those relationships, as they broke or were neglected or whatever happened, those relationships are part of the brain change and the worldview outlook. So one of the most important things about trauma is relationships. And if it's complex trauma, it's very hard for people to engage in and establish a trusting and kind of loving relationship. And it's something we need to keep in mind, because often we wonder, why aren't they involved? Why wouldn't they be? Why doesn't this appeal to them? That makes the recovery piece for us much more difficult. And it also means that a lot of times we'll unintentionally harm the people who we should trust the most, because we can't. So for those of us who have complex trauma, and clearly I think everybody on this session understands the impact of trauma, that piece for us makes recovery from trauma a lot harder, because we can't have those really safe and trusting relationships. I had something else I was going to share, but I can't remember what it is now. It's Friday and I'm running on fumes too.
I think we could all identify. Thanks for adding that. It's always valuable to have that relatedness, right, to an experience of either someone else or our own, to really understand how some of these things impact our decisions, our behaviors, and our views. But now with how do we foster post-traumatic growth, right? Positive change that comes from what we've been through initiates this post-traumatic growth, right? Like I shared in the previous slide about, some people being incarcerated and taking that opportunity as an opportunity for self-reflection of looking at what changes they have to do in their life. An individual might notice more clarity or meaning surrounding the trauma events in the sense of moving forward in their life despite these hardships. An individual might even feel able to integrate the event or events as a contributing to their identity. And there's a level of willingness to acknowledge the traumatic event that has happened, which can be harder than it sounds. There are many ways one can go about this. The most common one is therapy. One of the biggest factors encouraging post-traumatic growth is being able to emotionally process the grief and other feelings related to the traumatic event. Learning about the trauma. Some people don't even identify certain experiences as traumatic experiences, right? Because we're in the society of, push through and, move forward, and we kind of, swipe through and over a traumatic experience. And how is that being reflected in our behaviors, in our thoughts, in our, feelings, and so on. It is helpful to keep educating ourselves in that topic. With each new resource, an individual could unearth another layer of awareness to help navigate their own trauma recovery process. And at least for myself, a big book that helped me really identify and relate to and encourage me into treating and educating myself more around trauma is the book by Bessel van der Kolk, The Body Keeps the Score. I have it there, and I even have the study guide because I was really I started reading it. A therapist recommended it, and I started reading it, and I was all in, engrossed in it. And I found a study book, and it helps empower, encourage a lot of self-reflection, which also can help support or foster post-traumatic growth, and community support. And maybe I'm not the best person to talk about community support because I have a bias, and I think that they're integral to my recovery and my wellness journey. There's much research out there as well that shows that socializing with your loved ones and others who have been through similar experiences that can help support the trauma recovery process, as well as recovery from substance use and mental health. Johan Hari has a little outdated video that talks about how we, have been looking at addiction the wrong way, and the opposite of addiction is connection, and it's still relevant and exactly on point to this day. Maybe some of the language is not too, recovery oriented or person first, but the message is still very relevant in our current times. And there's a great value in joining support groups with other trauma survivors who are essentially peers who get what an individual is going through. I know a local peer recovery center who has their peers working with a trauma specialist to develop, topics and, group processing stuff so that peers can run trauma groups with peers. As the facilitator, and the clinician is just sitting around as an observer, right? In supporting after, if anything comes up for the ladies after, the group, because a peer is a peer and they stay in their lane, they're not clinical, but having that clinical person behind the scenes to really support the ladies and not going back to their communities or leaving the group really activated and reactivating their trauma is really important for that clinician as well. And trauma can be life altering. While commonly associated with painful outcomes such as PTSD, there are many benefits as well, like the lesser known post-traumatic growth. I think that, we often talk about, majority of the time, we talk about trauma-informed care, and trauma this and trauma that, and we don't leave too much space for talking about what happens after trauma and how we can still grow around that trauma, right? We're not going to ever get rid of it, but we can grow around that trauma. Now, I'm sure that most of you are familiar with a ROSC, right? A recovery-oriented system of care. I always add that wellness because it's integral, right? It's the intersection between treatment and recovery. Because again, it's not just about stopping the use. It's not just about going to a therapist. It's not just about, getting treatment, going to your doctors or clinical stuff, but it's more than that. But with recovery-oriented systems of care, it's a coordinated network of community-based services and supports that is person-centered and build on the strengths and resilience of individuals, families, and communities to achieve abstinence and improve health, wellness, and quality of life for those with or at risk of alcohol and or drug problems. This is a big focus, right? Ross has a big focus on supporting people in recovery from substance use disorder, but very easily can be adapted, right, to supporting someone with mental health, a trauma history. Because if we're supporting that connection, right, and creating this system of care for people with substance use disorder, all those things are also part of their person's identity, right? And so this is why I always put wellness at the center, or to lead that, because when we think of Ross, it provides a network support services, but through education, communities are strengthened by recovery-oriented activities that could prevent inappropriate substance use before it occurs. Traditionally, recovery-oriented systems of care have been viewed as long-term recovery-related activities that occur after a former substance use treatment episode. However, recovery-oriented activities and approaches are also part of the full continuum of care available to a person within a ROS system. Now, before I get into how wellness has its inherent place in ROS, let's look at the working definition of recovery offered by SAMHSA. And it's my favorite. And it goes as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. What stands out for you all in that definition? Self-directed, yes, right on. Choices. Stephen, yes. That's exactly what stands out for me. What's not in that definition? Self-directed and wellness, reaching full potential. You know why I like what stands out for me with this definition? It doesn't highlight if it's a substance use disorder that you're recovering from, if it's a mental health, if it's a physical injury, it doesn't identify none of that. The focus is health and wellness, right? The quality of life for the individual versus the things that are challenging their from anything. Absolutely, Jess. This is exactly why I love this definition, and not the fact that, it was peers who helped develop it, but it encompasses all of us. And now with wellness, a whole person strength-based approach, and Samson envisions wellness as not as the absence of disease, right? Illness and stress, but as the presence of a positive purpose in life. I should have underlined that one as well. Satisfying work, play, joyful relationships, and a healthy body, and living environments and happiness. Now, do you understand why wellness leads recovery-oriented systems of care? Because we have to, when we're working in recovery-oriented systems of care, it's more than just substance abuse. We're looking to improve, right? The presence of a positive purpose in all areas of the individual's life, because the goal is uplifting, empowering, and supporting for longevity in the health and wellness of the individual. I love this stuff. I'm a dork for it. I can talk about it in different series, but the diagram pictured here illustrates a Ross framework that includes the mission, values, goals, system elements, as well as the core functions and outcomes of the systems. The principles of a Ross in healthcare are closely aligned. Now, for example, right, invest in prevention and wellness, expand coverage, guaranteed choices. And this is where we have to create partnerships, right, in collaboration with insurances, develop our big A and little a of advocacy, where we can influence because of our experience as peers or because of our experience as, professionals in this space, advocate for the need for some of the people that we serve. Now, a ROS is implementing the provisions. The major components of a ROS is implementing the provisions of healthcare reform to provide high quality substance use services. So even if we're at this direct care level, whether we're working in an incarcerated setting or we're working in the community, we have to impact and plant seeds of ROS and the value of supporting the whole wellness of an individual to our supervisors to leadership to, that C unit or C level of leadership in our organizations, so they can see the value of a ROS system. To achieve reform, integration of substance use services will need to occur within the primary care settings. There's a big movement across the nation with integrated care, and even I know in educational settings, there's SAMHSA grants supporting, behavioral health, mental health, and social workers in being integrated in medical settings. But I would go farther than that, right? And including peer workers in these teams, community health workers in these teams, peer navigators in these teams, because the individual is more than what the symptom they're presenting and more than the diagnosis that that identifies them, right? Now, primary care providers will likely require additional education because boy, oh boy, a lot of the stigma and barriers happen at that medical setting. Not to say that, right, the behavioral health, community health, and community mental health is not, right? Because there's still some of it still there. But there's a lot of deep intentional work that has to happen with us as individuals, as part of these systems, to really eliminate and eradicate some of the stigma and bias that hinders people from seeking support from mental health, behavioral health, probation, all these settings that are connected to our well-being or that are intended to support our well-being. And it's important, right, to educate not just the providers through trainings on how to screen and intervene with at-risk populations or underserved populations, and on how to refer individuals with more service connections or needs to specific settings. Additionally, specifically for providers, may be required to establish new partnerships, enhance technology, establish quality improvement systems, expand capacity, recruit, train staff, and work with health insurance plans. And now, talking about health insurance plan, right? Funders. When we think about the organizations that we work for, when we think about incarcerated settings, who are their partners? Who's supporting these framework of a ROS or a wellness ROS, right? Because treatment and recovery does not only happen upon reentry. it should start when the woman is in the intake process, right? And in that, and I can speak for myself, in that detox stage of their entry into incarcerated setting. Any questions, thoughts so far? Insurance plan, man, I could do a presentation on that, and hopefully someday I get to do one trying to impact just insurance providers and insurance companies, because they're a hot mess the way they rule the world out here. But now, with power and peer recovery support services, peer recovery support is characterized by the provisions of non-clinical peer support, which can include activities that engage, educate, and support the individual as they make the necessary changes to recover from a substance use disorder. Each of the beauty of peer support is that now it's not just a substance use disorder. Now we have mental health focused peers. Hopefully someday soon we'll have peers that are equipped with supporting people through trauma, because self-help, post-traumatic growth happens in peer connections, right? But each of the partners in a ROS can play a role in the provision of recovery support services. When recovery support services are provided across a continuum of care, they support resiliency, open doors to serve access and engagement, and support long-term recovery. Person-centered supports bolster successful individual and family outcomes. Homelessness, yes, ERs, crisis teams. We do. We're everywhere. I totally agree. I know there's forensic peers in inside incarcerated settings. Now, while typically viewed as available post-treatment, recovery support services within the construct of a ROS can be offered before, during, or even in lieu of treatment. This approach and its supports are inclusive of pre-treatment as well as promotion of resilience and prevention in early or brief interventions, as well as in reentry, and probably most importantly at reentry. Now, some of the activities, peer providers offer valuable guidance by sharing their own experiences recovering from substance use, mental health, and maybe even a trauma disorder or trauma impact. By helping to build skills assisting in addressing specific needs that someone with substance use disorders face with as they are early in recovery, and by improving social connectedness and helping to identify new positive social environments upon their reentry. One of the roles of a recovery coach, for example, or a peer, are being a resource broker, right? And kind of connecting to those resources in the communities that might help meet some of the needs that they have upon reentry. Mentoring or coaching refer to a one-on-one relationship in which a peer with more recovery experience than the person served encourages, motivates, and supports a peer who is seeking to establish or strengthen their recovery and their success in reentering. And the relationship of the peer leader to the peer receiving the help is highly supportive rather than directive, right? This is the part of the activities or tasks to help support and empower decision making, right? That collaborative decision making, that autonomy to the treatments of whatever needs they might have. The purpose of resource connecting services is to connect the peer with professional and non-professional services and resources available in the community. That resource broker lens that I was previously sharing. And then with peer leaders, facilitate or lead recovery-oriented group activities. Some of those of these activities are structured as support groups, while others have educational purposes and may have components of both. The group activities that are structured as support groups typically involve the sharing of personal stories and some degree of collective problem solving. And see, this is one of those things that really separates lanes between a clinical provider and a peer provider, right? A peer provider is able to strategically use their lived experience to, ignite or empower action, right, and motivation in other individuals who are early in the process. Many of these groups are formed around shared identity, and this is why it's so valuable to have peers on teams, such as belonging to a common culture or religious group or shared experience related to the substance use, the mental health, or the trauma. maybe even, health issues. I know there's peer wellness coaches in now, even in medical settings that are focused in like diabetes, HIV health, and that kind of stuff. A person in early recovery is often faced with the need to abandon friends and/or social networks that promote and help sustain the substance use disorder, but has now alternatives to put in place to support their recovery, right? Peers support individuals and make new friends, and they support them in making new friends, making new positive sober connections. Um, the intention of peer-led recovery activity provides a sense of acceptance and belonging to a group, as well as the opportunity to practice new social skills, and kind of work through some of those things that, isolation is a big factor in criminogenic behavior. And so we're, surrounded by positive people and recovery, and, they have a future focus lens that I can easily rub off on the individuals as well. Any thoughts?
Daisy, I want to chime in just for a second here. And you made a great point about that early recovery piece and having to often, sorry for the noise, having to often, leave behind friends or, acquaintances. The whole piece around changing how you live your life is a big deal, because what folks need to understand is, depending on how long you've been sort of out in active addiction or experiencing homelessness, or you've been incarcerated, every one of those areas is a subculture. And that power of that subculture, just to think about it this way for a second, if the mainstream community has asked you to come in because they can help you with your challenges, and then they've done things like taken your kids, violated you, suspended your driver's license. There's 101 ways that those of us who came for help in the past have been harmed. And it's really through no fault of the system at the time, but today we can do a lot better. And the challenge of moving somebody who has been harmed back into that mainstream community is a real challenge, because we don't have trust. And you have to understand, up until about 2016, when a lot of white folks started to overdose on opioids, we moved from this punitive lock them up and throw away the key mentality to, oh my, this is now a public health crisis. That's important for us to understand, because while the mainstream community has made the shift here, sort of, it's in progress, the folks who were out, who have been harmed in the past, haven't. And those subcultures that they're involved in, as dysfunctional as they may appear to all of us, we thrive in them. They welcome us in with all of the things that the mainstream community says those are bad. So if anything happens to us in the mainstream community, especially in early recovery, don't forget that those subcultural communities that we used to participate in, they are right there, and they are ready to welcome us back with open arms. When you have a stressful day, all it takes is one of your associates, somebody you used to party with, to show up with some party material, and it's real easy to step back into your subculture, because it's familiar and it's comfortable, and you know how to thrive because you know the rules in it. And it's the same for the subculture of addiction is particularly powerful, but it includes incarceration, it includes homelessness. Every one of those have their own specialized language. So, and their sacraments and activities, every one of them. And so when you have people with all three, you are really engaging against three powerful subcultures. And I'll just finish by saying this. William White has written a couple of things about the subculture of addiction. And he's clearly pointed out that these subcultures are major barriers to recovery. And not only are they barriers, but they can enhance and even reinstate drug use for people in early recovery. Thank you for letting me share that.
Absolutely. I love that you added William White out there, because there's so much resources that he's offered, toolkits to support us to really look outside, what we're used to. Thanks for highlighting that, right? Because it takes us, starting in our own spaces, because not everybody's working out of the same, we're not all working through the same lens or with the same leadership, right? Some of us have a little pushback still to work through, but what state are you connecting from, Maria? Work in progress for sure. All right, I hope everyone had an opportunity to catch that QR code to complete the link. You're welcome, Maria, thank you. Isabel Kai has been so kind as to put the link also on chat. Make sure that we can, help us improve.
Oh, can you put it up one more time?
Absolutely.
Oh, thank you.
Thank you all for joining. Thank you, Darlene, Karen, Jason, Jennifer, Maria. Thank you all very much.
Daisy, this is Stephen. This was just outstanding. And I've been in the other two. This one was outstanding. Thank you for taking the lead and making it as powerful. I've learned several things, both from you and from folks in the audience. So love to be able to increase my own knowledge. None of us are experts.
Right, that's the beauty of sitting in this role, right? We come with a nugget of information and knowledge, but we also grow through, the discussion.
Yes.
And the sharing of y'all experience, both personal and professional, also helps supports us grow. I've accepted long ago, I don't know everything, and so I consider myself a student of life. And these opportunities, despite of my role, are a good place to increase my knowledge. So thank you all for participating and investing in your own development, right? And growing and expanding some of your knowledge. I feel like it's always like knowledge sharing versus knowledge giving.
Love that, Daisy. It's great.
All right, y'all. So to be respectful of time, and we're probably standing in the way of you and TGIF, right? The weekend. I hope you all have a wonderful, restful, and enjoyable weekend. Thank you, and have a good rest of your day.
Thank you. Bye-bye.